Medurstand, Understanding Medicine.
I'm Professor Azizur Rahman, and today we are going to talk about the treatment of hypertension. And those of you who have already watched earlier videos on burden of hypertension and the initial evaluation of hypertension, I think they will understand this lecture better. So those who have not yet watched those videos, I strongly suggest that they should watch those videos first and then come to this one to have a better comprehension of this treatment. When we talk about the treatment of hypertension, there are two basic questions. Why to treat? Now, this may look funny to professionals. It is a medical condition and it has to be treated. It's as simple as that. But why this is pertinent to ask this question is that many patients with hypertension, they do not have any symptoms, and many of them they are not actually diagnosed. Those who are diagnosed, they may not have any symptom, they may be in a state of denial, they just don't, they're not convinced that they need treatment. But we know that untreated hypertension can lead to a lot of complications, and I'll show you in different slides what are those complications. And we need to convey this concept to the patients and to convince them that treatment is absolutely essential, even if the patients do not have any symptoms. In fact, first time they may develop symptoms is when they're given treatment, but still treatment is extremely important. Then how to treat? This is again important. Our objective is to bring down the numbers. We have lifestyle changes methods and we have number of medication. How to make best treatment plan for given individuals, that will be the second part of today's talk. First, of course, the why to treat. You know, this is very interesting chart. You can see that blood pressure can be ideal, and this is upper normal, this is borderline first stage hypertension, and this is stage 2 hypertension. Now this is where we make a formal diagnosis of hypertension, which is currently the cut point is 140 by 90 or above. If multiple readings are 140 by 90 or above the office reading, then one is labeled hypertensive. Now we know that cardiovascular mortality risk doubles with each 20 by 10 millimeter increment in blood pressure. Now this from this point onward, from blood pressure, once blood pressure is diagnosed, now every 10, 20 by 10 millimeter of mercury blood pressure increment double the cardiovascular mortality risk. So this is actually very alarming. The risk is roughly approximately proportional to the degree of blood pressure. So it could become 4 times or even 8 times. But one thing which is very reassuring and encouraging is that once we bring down the blood pressure, it again lowers the risk. Not only when we bring it down to the normal, even when it brings us to the less than the cut point, risk further reduces. So that makes a very strong point that we should try to get it to the lowest acceptable to the patient, the lowest which does not cause symptoms. So I'll show you some data to support this concept. Of course, the minimum objective is to bring it down to the 140 by 90. But ideally, if we can bring it down further lower without causing any side effects, I think that would be better because we can further lower cardiovascular risk. So that is a very, very strong reason why we should treat an asymptomatic condition. Hypertension causes damage through vessels. There are multiple cofactors. I'll just show you. Basically, it damages blood vessels. So through the endothelial dysfunction, it causes vascular damage. You all know that all organs are dependent on vessels. Now, if vessels are damaged, any organ could be damaged. So hypertension works through various mechanisms with additional risk factors like hypertension, diabetes, dyslipidemia, atherosclerosis may cause myocardial ischemia, ventricular remodeling, hypertrophy, and then dilatation, and then maybe heart failure, various stages of heart failure, various types of heart failure, then end stage cardiovascular disease, that means heart failure, and then ultimately may result death. So hypertension is very, very, I would say, potentially serious condition. In itself, it may not cause any symptom, maybe just a little bit of palpitation or maybe headache, but it can cause serious damage by damaging blood vessels. Now, since blood vessels are important for all organs, so all organs are vulnerable. Uh, Now we'll talk about some organs specifically. This is just a summary. Hypertension can cause cardiovascular disease, various types, angina, myocardial infarction, heart failure. It could cause cerebrovascular accidents, again, both types, ischemic as well as hemorrhagic. It can cause chronic kidney disease, initially just albuminuria and then progressive kidney disease, and may resulting in the end stage renal disease. Then hypertension can cause various types of retinopathies, hemorrhages and exudates, peripheral vascular disease, and it may cause premature death. So these are some of the complications which untreated hypertension can cause. Now we will examine these in some more detail. Now let's first take CVD. What is CVD? CVD means ischemic heart disease. CVD means left ventricular hypertrophy. Now many youngsters would think that left ventricular hypertrophy is a pure physiological adaptation to high blood pressure. That is actually true, but we also know that this left ventricular hypertrophy in itself is a morbid condition. If you have two patients with same level of blood pressure, same duration of blood pressure, one with the other without left ventricular hypertrophy, the one with left ventricular hypertrophy is more likely to have poor outcome. So we consider left ventricular hypertrophy as a morbid condition. Then there could be heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. Now, I think our traditional concept of heart failure is that of the heart failure with reduced ejection fraction, and we give lot of importance to ejection fraction which we get from echo. So that is very, very true. But the point is that there are many patients, close to 50% of the patient with heart failure, who have ejection fraction which may be acceptable, which may be like around 50 or above 40%. So these are classified as heart failure with preserved ejection fraction. The cut point is 40. If somebody has symptoms of heart failure, signs of heart failure, but ejection fraction is less than 40, then it will be with reduced ejection fraction, and if it is more than 40%, it would be heart failure with preserved ejection fraction. Then dissection of aorta is one of the complications of severe hypertension, then fatal myocardial infarction. It could be the first manifestation, thus presumed diagnosis. Somebody was never diagnosed as a case of ischemic heart disease. He had hypertension, died suddenly, presumably due to a sudden myocardial infarction resulting in ventricular fibrillation. So CVD constitute is big burden, is one of the major complication of untreated hypertension. 24% deaths due to CVD can be purely attributed to uncontrolled hypertension. So that is a big number. We can reduce it to maybe zero if we control blood pressure very effectively. Now, the maximum benefit of treating hypertension in cardiovascular disease comes in preventing heart failure. If blood pressure is treated effectively and controlled for long term, heart failure is almost completely eliminated. And there is also marked reduction in dissection of aorta. But of course, there is benefit of on all the parameters. but these two are which are particularly benefited by effective treatment of hypertension. Now, the second one is the chronic kidney disease. Now, chronic kidney disease could have two-way relationship with hypertension. It just initially chronic kidney disease would manifest as just asymptomatic albuminuria. Even simple routine urine examination may not demonstrate the presence of albuminuria. You have to have the specific test for microalbuminuria. So microalbuminuria will progress to frank albuminuria, then ejection. This GFR will be reduced and progressively reduced to the level when patient would be called end stage renal disease, and patient would require some kind of renal replacement therapy. Now, ultimately, it may cause a resistant hypertension and may also contribute to malignant hypertension. Malignant hypertension is a condition where there is a very high blood pressure and patient goes into heart failure, acute renal failure, or hepatic encephalopathy. Luckily, this condition is now very common these days because we have very effective treatment. So I think hypertension and kidney has two-way relationship. Any chronic kidney disease, any renal vascular disease or renal parenchymal disease can cause hypertension, and uncontrolled hypertension can cause renal parenchymal disease, and both perpetuate each other. So once this combo develops, there may be rapid downhill and patient may end up having chronic kidney failure. And there are various mechanisms. It's just not simple increase in creatinine. Various metabolic derangements like hypocalcemia, hyperkalemia, and then raised creatinine. All these, they have adverse effect on the vessels. They contribute to premature CVD. Uh, of course, hypertension can cause CKD and chronic renal failure, but those hypertensive patients who have CKD, even at an earlier stage, they have much more chances of having associated CVD also, cardiovascular disease also. So you could say that chronic kidney disease is in a way CVD also, cardiovascular disease also. So I think that gives us another reason to treat hypertension effectively. The third part of this major cardiovascular disease is this cerebrovascular accident, and patient with hypertension may have ischemic cerebrovascular accident. The commonest type of stroke in patient with hypertension is ischemic. One might think that it would be hemorrhagic. Hemorrhagic CVA is also commoner in patient with hypertension as compared to normotensive. But even in hypertensive population, ischemic CVA is commoner than hemorrhagic CVA. But this one could be really devastating. Then there could be lacunar infarction. Patient with CVAs, they tend to develop small infarctions in the brainstem or the base of the brain, which may cause hemiplegias or monoplegias. So I think that is important. Then they may cause dementia, they may cause encephalopathy, and there are multiple problems. I think dementia also is possible. So these are the brain-related complications of hypertension. Mostly CVAs, three types: ischemic CVA, hemorrhagic CVA, and lacunar infarctions. 50% of the stroke deaths are related to hypertension. Imagine, stroke is a deadly disease. Now, many of the strokes are caused by hypertension, and 50% of the stroke deaths are directly attributable to hypertension. Don't you think that this is strong enough reason to treat patient with hypertension? Very, very important. Maximum reduction comes in ischemic CVS, and also I think no, sorry, not the ischemic, the hemorrhagic. Maximum reduction in hemorrhagic CVS, but also some ischemic CVS. and hypertensive encephalopathy is literally eliminated with successful control of blood pressure. Now, this is another slide showing the benefit of treatment, the overall cardiovascular benefits. It's a meta-analysis of 61 prospective observational studies consisting of 1 million adult patients, and the studies were extended over 12.7 years. And it has shown that just 2 millimeter decrease in mean systolic blood pressure can reduce ischemic heart disease related mortality by 7% and stroke related mortality by 10%. Now, just 2 millimeter reduction in systolic blood pressure, this big impact. In real world, we have patient with blood pressure of like 180 by 110. So we have the opportunity of bringing down the blood pressure by 40 by 20 millimeter mercury. And of course, this figure would also multiply by the same magnitude. So I think in real world, there is very, very good reason to treat these patients to bring down these fatal complications. So, summary of this part, prognosis of hypertension, if untreated, why not treated? Those patients who are not diagnosed, those patients who are diagnosed but they are not taking treatment, those patients who are taking treatment but treatment is not effective because they are not following it up and they are not taking the proper dosage. So, untreated hypertension can lead to stroke, can lead to heart failure, can lead to dissection of aorta, can lead to ischemic heart disease, can lead to chronic kidney disease. So many complications are caused by untreated hypertension. But good thing is that if we treat it with the right drugs, right combination pills, and we keep it under control on long-term basis, we can substantially reduce the risk of all these complications. Perhaps the patient with hypertension will not be equivalent to the one who never had hypertension. This is perhaps because our current treatment is not ideal. Patient may not be taking treatment properly, or some of the drugs may be actually responsible for some of the complication. But net, there is definitely marked benefit of the treatment. Major factor is BP lowering. We have number of agents available, but they all lower blood pressure. They have different mechanism of action. You can make a case that this particular one is better than the other one, and in some situations there are some drugs which are better than others, but our objective is to lower down the numbers. So whatever agent is available should be used, but of course in some situations there are some agents which are considered better than others. So if that is possible, it should be even better. So I think we have convinced ourselves that treatment is important, because untreated patient can end up having many complications, and ironically there may not be any warning symptom. It be just one bad day, one day which just devastates one's life. So I think one should not let that happen, and one should treat blood pressure, and then how to treat, and this point we are going to take up now. Uh, so our aim is to bring down blood pressure. We have already discussed, we have number of agents. So our aim is to bring it down to normal 140 by 90 or even lower if side effects are acceptable. Now we have lifestyle changes. Lifestyle changes are great things because they not only correct blood pressure, they will also correct many associated conditions. Like if somebody has dyslipidemia, somebody has a weight issue, uric acid problem, I think they will also be addressed by the same lifestyle changes. But our objective here is to bring down blood pressure. First of all, we talk about the DASH diet. DASH is dietary advice to stop hypertension. A complete program is available free on this website, but basic components of DASH diets are a diet which is rich in vegetables and fruits, and low in animal source food, low in meat, and low in salt, and also low in saturated fatty acids, and has more of unsaturated polyunsaturated or monounsaturated fats. So complete list you can find here, but that definitely works. Then we must work on weight. Uh, of course, weight is very important, but just to make it a little funny, I just say it more important than weight is pate. Pate refers to our viscera, the visceral obesity. We know that fat in the viscera is metabolically much more active than the fat in the subcutaneous tissue, and it is more closely related with cardiovascular disease. So I think we should particularly focus on the visceral fat. We could measure one's waist, and if it is more than what is recommended, 40 for men, 35 for women in inches, if it is more than that, we should work on waist and weight. So but the main aim is to reduce caloric intake. So whatever patient eats should eat in lesser quantity. Then I think we should also, of course, I didn't mention here, but exercise is part of our lifestyle changes. Just reducing diet may not be sufficient if you add regular exercise. Regular exercise means 150 minutes of aerobic activity per week, 30 minutes of walk every day, or 45 minutes walk or equivalent exercise 5 days a week. So that, along with dietary changes, I think that would have a very good effect on blood pressure. Then there are some exacerbators. That means they are not typically classified as causes of hypertension, but if you have blood pressure, if you have high blood pressure, these factors can increase your blood pressure. Smoking, for example, non-steroidal anti-inflammatories, many other drugs. And so the sleep problems, I think these exacerbators should be addressed, and if addressed properly, maybe that will also help to bring down the blood pressure. Every patient should be counseled about lifestyle changes and should be encouraged to start lifestyle changes. Many of these patients would actually need medication, but lifestyle changes will still be very important. Those who have very mild hypertension, just borderline hypertension, they may try lifestyle changes alone, but most others would need medication. Now, this is a busy slide. I will not go through it, and those of you who want to study this one, they can pause this video and just go through this slide. But I think I would just want to mention that we have number of classes: thiazides, angiotensin converting enzyme inhibitors, angiotensin receptor blocker, calcium channel blockers, beta blockers, mineralocorticoid receptor blockers, and alpha blockers, and they all have some plus points, some minus points, negative points. So I think those of you who are interested can go through the slide in detail and then resume watching the video. But I assume most of you are familiar with these drugs, so I'm going to move to the next slide. Now, there are various guidelines available. We have guidelines from JNC 8, we have guidelines from European Society of Cardiology, American Society of Cardiology, and we have International Society of Hypertension. But these guidelines are British guidelines called NICE guidelines. They are updated periodically. The latest guidelines are of 2019. And I think, first of all, the first step is diagnosis and evaluation and lifestyle changes. Diagnosis and evaluation was discussed in a separate lecture, and lifestyle changes we just talked about. So every patient, after making a diagnosis, should start lifestyle changes. But as I said, majority would require medication. We have step 1 medication, step 2 medication, step 3, and step 4. Now let's talk about the step 1. Patients should be classified in categorized in one of the two. Those patients who are 55 or younger, they belong to this group and they are best started on RAS blockers. RAS blockers consist of angiotensin converting enzyme inhibitors or angiotensin receptor blockers. A stands for RAS blocker. They represent both groups, angiotensin converting enzyme inhibitors and ARBs. Initial NICE guidelines, they recommended that we should start with ACE inhibitors, and if somebody does not tolerate ACE inhibitors, then we should move to ARBs. But current guidelines, they indicate that either one is okay. Angiotensin converting enzyme inhibitors or ARBs, both are almost equally effective and both are equally beneficial. So I think depending upon physician preference, you could start with any agent. Although ARBs, they probably have better tolerability. So I think most physicians would probably choose an ARB, but there are some who are more comfortable with ACE inhibitors. Either one is okay. We start with any of these agents. We typically start with the small dose and we then move on to moderate dose. We monitor the patient. It is, I think, never an urgency, mostly not, to bring down the blood pressure very fast. So unless patient has hypertensive emergency or urgency, we will have a separate lecture on that. Most patient, you can just start some medication and call the patient back after some weeks, and patient can be asked to monitor blood pressure at home. And then we increase the dose. We can take to the maximum or the maximum tolerated. Then we have, I think this cartoon appears because these days we have this corona virus infection, COVID. There is a relevance because COVID, this virus, this attaches to ACE2 receptors, and there is a lot of discussion about the benefit or the potential risk of this class of drugs. But most society says that there is no convincing evidence in favor or against. So current recommendations are those who are on RAS blockers, they should continue to be on RAS blockers. So I think on the merit of RAS blockers, they should be prescribed. This COVID should not stop you from prescribing these drugs. Those who are already taking, they should continue to take. Now, this other class is people who are 55 or older, or are black people, African black or Caribbean black, not just dark complexion, but these ethnicities, they are actually low renin groups. They do not respond to RAS blockers very well. So for them, the preferred treatment is calcium channel blocking agents. And though we have 3 calcium channel blocking agents, but in the guidelines we mostly mention amlodipine. So these patients can be started on amlodipine. Amlodipine comes in 5 milligram and 10 milligram. Typically we start with 5 milligram and then we monitor the patient and then we can move on to 10 milligram. So I think with either of the two agents, about 30% of the patient along with lifestyle changes will respond and their blood pressure will be low to the acceptable goal. So I think they may be continued, but those who have not responded to the maximum doses of these agents, they have to take step 2 treatment. Step 2 treatment is very simply combining these two drugs. Somebody who started from here should then we add RAS blockers. Somebody who started with RAS blockers, we should we should add amlodipine. So again, we give combination, and if combination pill is available, that should be better because that improve compliance. Again, another 25-30% would be controlled at step 2. At every level, we must make sure that patient is actually taking treatment. So we move to the next step only when we have ensured that the prescribed medicine is actually being taken. So there would be some patients who would not respond to even this combination. This combination works very well because their effect on blood pressure is complementary, and their effect on side effect is actually they cancel each other's side effects. For example, edema caused by amlodipine will be lessened if there is concomitant administration of RAS blockers. There is a very interesting mechanism for that. I will not go into that detail, but if they are combined, they do not only work better, they actually are tolerated better also. Then some patient, about again 20-25% would not respond to this one, so we will need the triple drug combination. So patient on amlodipine, the A is for RAS blocker, patient is on RAS blockers, patient is on amlodipine, and then we add a diuretic from thiazide group. It could be chlorthalidone, it could be hydrochlorothiazide, or it could be indapamide. Indapamide is perhaps the best because it is metabolically inert. It does not cause hyperuricemia, it does not cause dyslipidemia, it does not cause hyperglycemia, and it has got very, very good 24-hour action. And I think most authorities, they would favor indapamide, but they consider chlorthalidone or hydrochlorothiazide also acceptable. So any of these agents should be added either as a separate pill, or we have triple drug combo also. So I think patient should be given 3-drug combo. In any group, we have various strengths. So we'll start with the small dose and then move on to the moderate dose and the high dose. So after the triple drug combination, still there would be some cases who would need a 4-drug combination. And then the fourth agent is the most recommended is mineralocorticoid receptor antagonist, like spironolactone. But we also have eplerenone or any other agent, alpha blockers or hydralazine or any agents based on your experience and based on availability can be added. Now, did you notice that beta blockers are not mentioned here? NICE guidelines, they do not mention beta blocker in the first year, but they do acknowledge that they could be very important. So at any level, if there is a compelling indication, then you can use beta blocker, typically in combination with these agents. So the compelling indication could be ischemic heart disease, compelling indication could be a patient with tachycardia, palpitation, anxiety, or compelling indication could be heart failure. So depending upon the compelling indication, beta blockers are typically added to this treatment regimen, and typically they are given in a relatively small dose. Previously we used to give large doses. So I hope I was able to give you some outline of the treatment plan, and these are the guidelines given by NICE. There are some other guidelines which do not prefer any agent over others. They just say that any of the 5 available agents can be used, or you could use them in high doses, or you could combine them. I think it is up to one's own judgment, but NICE clearly says that combination pills are better because they give you better efficacy with minimum side effects. Now, these are the guidelines issued by European Society of Cardiology and European Society of Heart, and they say that initiate with dual combination. Why do they say so? Because many trials have shown that if we treat patient with hypertension, majority would need 2 or more pills. Only small percentage would respond to single agent. So on the basis of that observation, they have recommended that you should start with single pill but 2-drug combination. Now, initial therapy should be dual combination, 1 pill but 2 drugs, and these 2 drugs could be, one has to be ACE inhibitors or ARBs, and it can be combined with either calcium channel blocking agents, amlodipine, or it could be combined with a diuretic, hydrochlorothiazide, chlorthalidone, or indapamide. We have no combination with indapamide built in. I think there is one. Yes, there is one. So we could use the combinations or we could use them separate. But European Society of Cardiology and Hypertension, they say that one pill combo should be preferred in majority. And they say that single pill, single agent can be considered in those patients who have just borderline stage 1 hypertension with low risk, that means no additional comorbidities, or the elderly, very frail people. They should be started with single agent, but all others should be started on two drug combo based on our experience that most patients they actually need two drug combo. So to save time and to have relatively faster control of blood pressure, it is recommended that you start with the single pill but two drug combo. And the two drug combo would be a RAS blocker with amlodipine or RAS blocker with a diuretic. Now, those who do not respond to this, we can move on to triple drug. And the triple drug would mean this combination of all three: a RAS blocker, calcium channel blocking agents, and diuretic. Please note down that within a particular group, we have various strengths available. So in step, we would have maybe two or three different strengths available. So we would move within the group from mild to moderate and then the higher strength. So then there would be some patients who do not respond to three drug combination. So the definition of a resistant hypertension is somebody who is not responding to the adequate dose of triple drug. Now, how to define adequate is at least 50% of the maximum recommended. So if somebody is taking at least 50% of the recommended dose of the three agents and adherence is ensured, then you should consider that patient as a case of resistant hypertension. Now, in resistant hypertension, you could add either of the other agents, but spironolactone is the most favored. Uh, the starting dose is 25 milligram or maybe 50 milligram, but you could go up to maybe 300 milligram. And I think if you're not very comfortable, then you may consider the patient to a specialist. He may be or she may be able to control it better. Then again, beta blocker, wherever you feel the need, you could add beta blocker. So I think the point is that majority of the patient should be controlled with one pill combo drugs, one or two pills. This is to improve adherence. We know that giving lesser number of pills improve compliance. And the ultimate aim is to improve compliance so that the blood pressure is controlled. So I think we have covered both the agenda items, how to treat and why to treat. So now let's come to the summary points. I think before we discuss summary points, some kind of monitoring is very important, because prescribing medicine does not mean that blood pressure will be controlled. Patients should be encouraged to have home blood pressure monitoring once or twice a day, depending upon blood pressure. If blood pressure is normalized and every time patient checks his blood pressure it is normal, then it can be measured less frequently. But I think once a week is the bare minimum, and you must follow the proper technique, and this was discussed in the first lecture. On every visit, for whatever reason patient visits the doctor, blood pressure should be checked, and periodic lab evaluation. And this will be based on patient response. I think maybe once a year, patient may have kidney function tests like creatinine and urine examination. Patient may have eye checkup, and patient may have echocardiography also. Once a year would be very reasonable, but less frequent may also be acceptable, like every 2-3 years should also be okay. Now, the summary: treatment of hypertension reduces cardiovascular disease, morbidity, and mortality very significantly, and it is very cost effective. Mostly, patient would need just one or two pills, which are not very expensive, but they can prevent many complications, and those complications can be very, very expensive from treatment point of view and from loss of productivity point of view. So I think there is no doubt that treatment of hypertension is very strongly indicated. And primary objective is to get BP to goal, but how do we do that? It is also important, but we should never compromise on our primary goal. In resource constrained societies, if you have some drug which may not be considered otherwise ideal for that patient, but you use it because that is the only one available, but we just want to bring down blood pressure to goal, or at least reduce by 20/10 from the existing blood pressure a patient had very high blood pressure. Single pill solution for most, and this is to improve compliance, as I made the case, and as the recommendation made by European Society of Hypertension and European Society of Cardiology, and also endorsed by International Society of Hypertension. I think we should start with low dose two drug combination single pill, then we move on to full dose two drug combination single pill, then low dose triple drug combination single pill, and then full dose three drug combination single pill. And those who do not respond would need another pill. So I think most patients would not need more than two pills. Now this is important because more the number of pills, poor is adherence. These patients with hypertension, they are likely to have many other conditions. They may be taking medicine for their diabetes, for their dyslipidemia, for their uric acid, for some arthritis. So it is important to keep the number of blood pressure medication to the lowest possible. So single pill solution for almost all. So that was all about treatment of hypertension. I hope I was able to give some overview. Of course, there's a number of other things which could be discussed. One single agent can be discussed in detail. Different antihypertensive agents can be discussed and compared, but that would be beyond the scope of this lecture. This was Professor Azizur Rahman from Medurstand, and I really look forward to see you in my next lecture again on hypertension, and we will address secondary hypertension and resistant hypertension. So thank you very much.